administration, just anywhere. But particularly for what we are dealing with, is very important because one nomenclature that is all your havoc in a community, in a country, in a region, and in the world. And so we have to be very careful as professionals and as lay people. That is why when we provide you these briefings, we try to make them as simple as possible so that all of us can understand. I know some interviews that have been done by New Narratives and FPA and LNTV with Willietta and Gloria. We have gone to the extent of speaking very, as broken as we can, the English, so that the layman in the village, the laywoman in the village, Ma Hawa and Papa Flomo can understand what we are saying, and Uncle To. So we go to the southeast too, so that I don't say I'm only talking about nothing else. So that's where we are with mpox response. We do expect that vaccines will come in. The National Public Health Institute have repeatedly put in for vaccines with their request with the Africa CDC. What we gathered is that before we could have these properly arranged based on protocol, based on requirements that needed to be met, we were informed by the Africa CDC that there was a communication there requesting vaccines. That came from the Ministry of Health. These vaccines, let me come to that, are not the regular vaccines that are given in a clinic on a regular basis, like polio vaccines, like hepatitis vaccines that you go to get, three doses for boosters. These are emergency use authorized vaccines. What does that mean? Under certain circumstances, when there's an outbreak, science have developed so much that now we are able to produce vaccines just in little over 6 months to a year. Why? Because the technology that we've developed in the past that we thought was not viable was brought to life when we had a COVID pandemic. That technology is called the mRNA technology in vaccine production. With the rapid speed and investment of the US government and the European government, companies like Pfizer, BioNTech, etc., were able to utilize this technology to produce mass of vaccines that were given all over the world. So, but the study that these vaccines undergo may not be as thorough as we will go through the regular clinical trials when we produce medications, pharmaceuticals, and then vaccines. They go through the rigorous clinical trials over years. It takes like 10 to 15 years before they can bring the vaccine or that medication to the market. But nowadays, technology has advanced so much that we are expediting these things because of the way the pathogens, meaning those things that cause us the disease, those bacteria, viruses, etc., the way they are changing themselves as well, they are mutating. So we are at that stage where even the NPHIL currently, and we will get there, is on the path of acquiring some tools with some of our young scientists that we have here, including myself and our epidemiologist. We will be doing a lot of research that will lead us into research and development for vaccine production of major diseases that are affecting us. We'll be looking at Lassa, we'll be looking at COVID, we'll be looking at Ebola and malaria, among others. But we will do the best we can to at least confine ourselves in the initial stages with the technology so that we can become effective and efficient. So we will be doing that. The NPHIL, our leadership, will be doing that. We will also be researching and developing those brains in order to be able to produce our own diagnostic tests and our own vaccines. That is going to be done in cooperation with others in the region. These efforts are collaborative. So we will be collaborating with institutes like the Gushi, institute like Pasteur, MRC, etc. But the fact that we now have those technologies gives us that before, Africa as a whole was just sitting and waiting for vaccines and diagnostics. So these are the meetings that we have been having in these recent times in the DRC Congo, in South Africa, in Liberia. High, let me put it that way, right on the African continent, and manufacturing also. So it would be that we after CDC, along with all of the national public health institutes, which are branches of the Africa CDC in the countries, that's the path we are taking. We also want to emphasize in this regard, as we talk about technology, that again, we were able to it is a very significant gain for our country through this entity, because you can talk about vaccines production, research. You can talk about diagnostics if you don't even know what you are looking at, what you are dealing with. So we lacked those capabilities before, but now we have that capability. I think it's a real good plus for our country, and thanks to all of the young scientists here and the team, the DRDE and diagnostic division that were able to capture that through the programs that we design here. And thanks to the Africa CDC and the WHO, as well as other entities like the US CDC, UNICEF, AFINET, and all of them, for their assistance in these regards. So we're able to now do that, through which we were able to determine that we have clay 2B here in Liberia. Now, we also know that we have clay 2A, so we are able to now know what we have. And these guys are at the National Reference Lab. They're just playing with this technology now. I mean, they're having fun. The next thing we want to do is, you see these technologies are on different platforms. It's like a cell phone, but you have, somebody has Samsung, and you have, you have BlackBerry, or you have, I use BlackBerry, and I still do. Or you have iPhone, Disclaimer, I am not promoting any product here, but it's just to give a classic example. Now, you know that maybe the Samsung has what, 2 slots, right? Double SIM, right? iPhone, just, 1 SIM. So you have different capabilities, different opportunities. So we are going to train on the other platform for sequencing. That platform allows us to sequence genes that have all, what we call a lot of bases. It's like if one bacteria, let's put it that way, or virus is, I just want to give you a simple example in terms of height, is 4 feet high, and another bacteria is like 20 feet. So you can see the difference. Now one machine will be able to do those little ones, and the other machine will be able to do the bigger ones. So those are the platforms. So we are going to learn on the next platform called the MySeq, and that gave us an ample capability to sequence more pathogens, viruses, bacteria, etc. So that's the direction we are going, and we really want to thank you for carrying this message out. So the map of sequencing on Africa used to be rare. In 2016, 2017, we have only 4 or 5 grains, 5 countries. So any country that is added there, then they color a grain. In less than this time, can you imagine, like NPHIL was not found that time, right? But later on, 9 years after NPHIL was founded, and after that time till now, NPHIL has now placed Liberia on the map, and that area is now green. The lady presenting was joking, he came up to me after I made a presentation at a conference that, oh, so map is outdated. I said, yes, outdated, you need to change it and color Liberia green. So these are the platforms that we are playing with. Once we get those two, we'll be very versatile. That brings me to the Lassa fever suspected case and confirmed case, that case which passed away in the US. We got the sequences from the US. What we intended to do was, now we have our sequencing capability, right? So we have now done sequencing of the most recent ones that we had from the region where that person who passed away visited, so that we are able to compare those sequences with the sequences that they took, the ones they took from that patient, and were able to analyze in the US. The file is so heavy that we are still finding means of sending it out to our colleagues. So if our US CDC colleagues are listening, we've completed the sequencing. We are now finding a way to have it sent to you because of the large file and limited internet strength here. So we're doing the best we can to have the file sent out. Excuse us as LDC is switching over now, so we're all aware of these kind of conditions. So that is it for the Lassa. So, still on Lassa here, as you know, we are also responding to multiple outbreaks. So it's not just mpox that we are responding to. We are responding to Lassa, we are responding to measles, and a few other outbreaks that keep cropping up. Today we have 39 positive for Lassa out of 231 suspected cases. So we have 231 suspected cases, right? These cases are only suspected. We think these people have it because of the symptoms and everything, which is evidence also. Then we go deep down into more evidence gathering to take the samples and then test them. So those tested ones are the confirmed ones, and those are 39 positive out of the whole 231. So we want to distinguish that. Now, the interesting thing is, although this may be negative, they may be carrying something else. So there where the sequencing capability gives us that latitude, that ability to look at that sample again to see what else could be in there if, in fact, Lassa is not there. So then we have two of those samples that were indeterminate, meaning we couldn't tell whether it was Lassa, it possibly was, or it was not. There are test indications. It is those indications that we go back to say this is positive or this is negative. Now, when it's confusing, it's giving us mixed signals, then we say it's indeterminate. That brings us to this indeterminate situation with the viral hemorrhagic fever that was reported as a suspected case in the Republic of Sierra Leone, our neighboring country. I believe most of you may have followed that on different platforms. Some were saying that it was just internet misinformation, but it was not. Here at the NPHIL, this leadership have tried to establish good cooperation with the other NPHILs in the region. So we cooperate and collaborate with the Ministry of Health / NPHIL in Guinea, and then we also cooperate and collaborate with the with the National Public Health Agency in Sierra Leone. Similarly with Ivory Coast, just in a sub-region. Then outside of here, of course, Mali, Nigeria, Ghana, etc. So when these things happen, we are on the basis of public health transparency and accountability, we inform each other, particularly these three countries, knowing where we came from with Ebola, which is a viral hemorrhagic fever, one of those ones. Then Marburg, another one. So knowing where we came from with Ebola, we are very vigilant. Our surveillance system is very keen, and we test for those regularly. When I say regularly, we test for those regularly. That's the only way we will know if something has happened or not. Now we have the capability to do the testing. We are now doing it. So in Sierra Leone, almost like 4, 5, 6 weeks ago, in the Kono region, which is the eastern part of Sierra Leone and the western part of Liberia, just right in that region where our border is, they suspected that a healthcare worker has symptoms of a viral hemorrhagic fever. Okay? They only suspected. When they suspected that, the patient left the Kono region, went to Freetown, and by the time they did treatment and other things, that patient passed away. When the patient passed away, of course, they had taken some samples. They are not known. Then they took some samples. When they tested the samples, right? You remember back in the days, it took like 2 months for us to get a first Ebola sample back, the result, back to Liberia. Nowadays, since that time, we have all developed certain capabilities that we are able to do these tests now. So when they tested it at the 34 Military Hospital in Freetown, the result came out indeterminate. So here we are. They only suspected. Then the results came out indeterminate. So there was nothing confirmed. At that rate, nobody could say they detected this or they detected that. We have the same situation here sometimes where I just read to you 2 of the samples that were indeterminate. So we couldn't say whether it's Lassa or it's Lassa. And then we have to do other things. So this was the case with this viral hemorrhagic fever case, suspected case. Since it was indeterminate, the Sierra Leonean National Public Health Agency, thanks to Dr. Fodesa, who was the executive director there, our colleague, and the team, they were able to do their contact tracing immediately. And then they had almost like 291 plus contacts that were listed. They followed them for the 21-day period. They were isolated and then followed for a 21-day period to see in between that time if they would develop any symptoms. Because the thing can be hiding somewhere and later on it can start showing its ugly hair. So during that time, we were in constant communication with each other. The executive director of the NPHIL over there and myself here, along with the team of the NPHIL here. We were also in communication with the colleagues in Guinea. And we continuously monitor. What we did on the NPHIL side was to immediately get our DRDE, to start activating our port health officers and the district surveillance officers, the zonal surveillance officers, I mean every layer that had to do with disease detection and detective. So we're on the alert. We wrote Dr. Sa indicating to him that we have heard of this and we got into discussions with him on what measures we have put in place. Then we had a discussion with him immediately, and together we all put in place the requisite guidepost that will create the situation whereby if there was anyone crossing over that was suspicious, we will be able to arrest the situation. So along the border with Sierra Leone, we had our team activated, so the team activated and the port health officers. They did the same on their side of the border. Because we were cooperating with each other, we all designed the strategies together. Then we asked if any of the listed person had from their end crossed over. Because these are questions that they would have asked us also. Then they said, no, we have all of them quarantined, isolated, and we are monitoring them. None of them have crossed. But keep watch, because we can never know when that happens. So we were always on the alert, looking at all of those symptoms, looking for all of those symptoms when people cross over. The number one thing, which is fever, then of course, the other symptoms. In a period of time, we have wanted to see what was happening so that we can then institute other measures. For example, evoking the chlorinated hand washing at the border before crossing, which we are going to do, and we'll announce that as of this press conference. We will reinstitute the chlorine water at the border, and for counties that are like Cape Mount, Lofa, Bombing, and within this period of time, we will decide, but immediately we want to institute that. So chlorinated water hand wash will be instituted and declared. Hand sanitizing also is a component of that. So coming to the story, that's where we are. We have written, and you will receive all these communications. The letter to Dr. Sa was December 1st, and it says here, a report of a suspected case of hemorrhagic fever infection in Sierra Leone. And before we got into those discussions, in their own publications, they also said suspected case of hemorrhagic fever virus or viral hemorrhagic fever. You can ship those words. Either way, the message will still go. And when we issued our press releases, they also carried viral hemorrhagic fever suspected cases that which had samples that were indeterminate. And so we followed the situation in Sierra Leone. We are very glad that the medical establishment here in our country is following the NPHIL very, very, I think, keenly. Unfortunately, in the last couple of hours, 24 to 48 hours, we've gotten lots of calls as to whether in Sierra Leone they heard that there is this happening there, and they're now coming to Liberia. We heard it from where? From the JFK. That's the release that came from the JFK that says suspected outbreak. That's a different thing when you talk about an outbreak. All of what we have been talking about have just been suspected case, suspected case, suspected case. Not even NPHIL talk about an outbreak of VHF, the viral hemorrhagic fever. And so it started to have people on edge. That is why at this conference we thought we should make that clarification to our people, to the region, and to the world. That number one, there is no outbreak of viral hemorrhagic fever in Sierra Leone. Again, I repeat, there is no outbreak of viral hemorrhagic fever in Sierra Leone. Just as I have explained, there was a suspected case. There were lines of contacts that were followed for the 21 days. They are all now being released after those 21 days. But as a good practice, I had spoken with our colleague there. They will still follow them up, you know, to see if anything develops after the 21 days. So we just wanted to make that very clear. We communicated with the JFK authorities and brought this to their attention, because in the release we were quoted. I had tried to speak with the authorities there, but they didn't get any call back. So we wanted to make that clear to the Liberian people that there is no outbreak of viral hemorrhagic fever in Sierra Leone, and the NPHIL did not report that. So if that can be your headlines, it will be one of the best headlines you will get out of here. No viral hemorrhagic fever in Sierra Leone, reports NPHIL on behalf of NPHIL. You have a very good headline. But one thing we want to really appreciate the JFK about is that quick jump to set up themselves, right? You know, these things are difficult to handle. There's a positive in this, that because of what we were doing, they were following us and follow us very keenly. They followed the National Public Health Institute. They were able to then, you know, get the medical staff informed that, look, we heard about this thing through the National Public Health Institute. Let's get ready, because we had our experience before. So they were very proactive. In being proactive, which we very well appreciate, there was just a slight mistake, and this would have caused some havoc. So we really appreciate that proactiveness, and we look forward to, you know, talking more. Our lines are open, just as you have always been calling us. We will talk to our JFK colleagues. They can come over here anytime, ask any of our divisions. We are always here to speak to anybody. The Ministry of Justice had called on us one time, and I went there myself and spoke with Councillor Oscar Toy. We had a very beautiful conversation on Mpox. Then I was also called by, at the time, the acting president, Honorable Sylvester Grisby, at the Ministry of State for Presidential Affairs. And he stays late at work. So when I was going there that day, I thought I would miss him. He had written me and wanted us to talk on MPOX and response. He said, my man, you came in. Now we are hearing MPOX in Sando and Brasano. MPOX in Lofa, the president from Lofa. So what are MPOX doing to us? So we joke about it, and we told him, well, you can find it other places too. In Lima is there. So maybe the vice president would have called me also. Well, you know, we have these sporadic cases of MPOX. We don't have a cluster yet, but what we call cluster meaning there's so much and then grouping together in regions. So we still have these sporadic cases, and they are coming up, but we keep handling them, and people are giving cure. So, yeah, so we are open to discussing with anybody on anything that is happening here. We send the Ministry of Health numerous information, like the EPI bulletins, these bulletins that come out every time. The Ministry of Health receives them. The Minister herself receives them. And we text each other. I text every little thing that happens, I text them. Sometimes what I do, I also text the board people, I text them also, so that they can know what's happening to the institution that they are, you know, board members of. So I text the chairman and feed him with this information so that they know real time what's happening here. They don't have to wait for, you know, the bureaucratic quarterly report to hear. By the time we go to that quarterly report, then everybody knows what's happening already. So we do that on a regular basis, and we will continue on that. So our lines are really open for anybody, all of you, the press and the public. We receive, in fact, reports of MPOX cases from the public. It will interest you. Some of the cases that we are enumerating here come from the public. The public report that. So it tells us that our communication is going very clear and clean, and people are responding. UNICEF has been doing very, very well by helping us to do this risk communication awareness in the local vernacular as well. And it's been spreading all around the country. So I would like to stop this far and entertain questions, and then we can move on.
Thank you very much, DG. Okay, distinguished colleagues from the media, you heard from the DG that the purpose of this press conference. There is no evidence, did not say that there is an outbreak of HIV in Sierra Leone. We said a suspected case. And so we call you to make that clarification and disseminate the information for the benefit of the larger society. Having said that, we will not entertain question. You call your name, institution, and pose your question. Yes, sir.
Good afternoon to all. My name is NPHIL Mansari. I was working for Heritage newspaper.
Nice seeing you. For the first time, face to face.
Yes. From the case, the suspected case.
Yeah.
The history we follow, even a report from BBC Profile.
Yeah.
He mentioned that the facility has traveled to Liberia on a medical trip. And so, as a NPHIL trial, which part of of the country that the woman traveled to, or where they conducted a medical exercise upon my return to Syria.
In our discussion with the director and his team at the National Public Health Agency in Sierra Leone, that did not come up as some information that the suspected case did or may have traveled into Liberia. The only, from the case history, what we learned was this case, this person had traveled to Freetown in order to seek further medical care. Our concern was those who came in contact with this case may have crossed the border. Now, that was our concern. So that was when the case, the story was developing when Umaru reported. So the information he gathered is what he reported. If what you're saying is exactly correct. I think I read that also. I read Umaru's report. But then what we were focused on was if any of those contacts travel into Liberia, and that was our concern. Because the case may be already gone, and if it were a confirmed case, full-blown, with no contacts, crossing into Liberia or Guinea, we would have been out for something. But it's good that we just arrested it right there. Those again, they had 291 plus listed contacts, which is very good and huge. And those contacts were isolated, contained, and then followed over the 21-day period time, and a little over, in order to ensure that there was no symptoms, there were no, not those classical symptoms, and then they were declared, free.
Another question? And then this press conference, the one richest press conference. Another person?
Yeah.
Yes, sir. Your name and institution?
I'm Yekezi Zowe from Spoon Evidence TV. Dr. Yan, you talk about research being carried out by the Public Health Institute to determine possibilities of producing vaccines for common illnesses in Liberia. Is there any timeline attached to that?
What we are gathering now are the tools. We have the capability here. The first thing is to gather the tools and the equipment, and then the resources to do that. We have been having goodwill from the travels we've been doing and the conferences we have gone to, from the Africa CDC and many other entities that are very well willing to support in that respect. So in research and development, you don't necessarily give yourself those rigid timelines, because it's not a thing where you have a block here and you say, I'm going to build a house and it will take me 3 days to build a house, and you build a house. It goes through a lot of steps. But we have taken the first step, which is very significant, that we want to do this. We have the brains, we are gathering the tools, and then we will start doing that. We hope that within the next 24 to 36 months, we will start having hands-on work being done and some initial results coming up. So we have already been in contact with a few other entities, and that collaboration has started already on diseases like Lassa, which we are faced with here greatly, and then we'll jump to other diseases once we get to have the science and the technology aspect within our grade.